Hello, everyone, and welcome to the National Action Alliance for Patient and Workforce Safety webinar for July. This is the July webinar in our national webinar series, and today's focus will be on making healthcare safer by design, redesigning for safety, efficiency, and burden reduction. Just a few housekeeping notes before we get started. My name is Fran Griffin. I will be the moderator for today's session. I'm a consultant in patient safety and quality, working with the AHRQ team on the National Action Alliance. Today's webinar will be recorded and available for viewing on the Alliance website. Throughout the session, we encourage you to use the chat function to engage with us by posting comments, feedback, or any questions that you may have. Closed captioning is available, as you can see with the image displayed on the current slide. So with that, let's go ahead and get started with our important topics for today around designing for safety. So one of the things that we were talking about as we were planning for today's webinar was our framing. So let's start with the questions to run on. So this is the framing we use for each of the webinars. 2 questions to help us think about the topic, what we want to talk about, and what we hope to hear from all of you. So our framing for today is, what are the safety design strategies that exist that healthcare organizations could use now to redesign their processes to prevent harm? And what are strategies that some healthcare organizations are already using that successfully incorporate safety engineering principles to prevent harm? As we were planning, I shared a story with the team of an experience that I had many years ago when I was practicing as a respiratory therapist at the bedside. And back at that time, and I'm really going to date myself here, ventilators did not have the option for hyperoxygenating someone before suctioning. Any of you who work in clinical care know that before a patient who's on a ventilator is suctioned, the best practice is to hyperoxygenate them so that they don't desaturate too badly during the suctioning process. But we didn't have an option to do that with a single button on the old ventilators. We would have to turn the dial or the setting for whatever oxygen level they were on to 100%. And so what I and my colleagues would do, we would turn it to 100%, prep for suctioning, do the suctioning, and then afterwards, we had to rely on memory to go back and put the ventilator back to the oxygen setting where it was. And of course, being humans, many of us, myself included, frequently forgot to do that. So sometimes I'd come back an hour later and discover that, oh my gosh, I never turned the oxygen back down. So we all started coming up with our own strategies. My strategy back in the day was I used to take my pager, since that's how we all got contacted, and I would put it next to the oxygen dial so that when I turned it up, if I walked out of the room without remembering to turn it back down, I would realize pretty quickly that I didn't have my pager, and when I would go back to get it, it was next to the oxygen dial, and that was my reminder to myself to turn it back down. It was not a great strategy, but it was better than relying on memory. And my other colleagues all had similar tricks that they used to help prevent this issue. What we also did, though, and this is going to be an important theme in some of what you hear today, we collectively were sharing that feedback to the manufacturers of the ventilators at conferences when the sales reps would come in, and they heard the voice of the healthcare workers, mainly respiratory therapists, probably also a lot of nurses. And so in the future iterations of the ventilators, that became a button that was added to ventilators where you could just hit a button and it would provide 100% oxygen for just 2 minutes and then automatically shut itself off. So it just speaks to the fact that everyone at the front line is identifying issues every day, coming up with their own workaround solutions, and their voice is so important because it will help us think about what's the next type of safety engineering principle that we need to bring into any of our devices or processes. So just a little bit of framing. We had a good discussion as we were preparing for today's session after talking about some stories like that. So now we have a question for you, and this is a question we'd like you to think about as we go through today's session. And that is a question we will ask for your feedback on later on in the webinar. So if we could go to the next slide, please. So we would like you to think about, what would you wish to redesign in your organization for safety? You may get some ideas from our speakers, or if you have already redesigned a process or system to be safer, more efficient, or less burdensome, we'd like to hear from you and have you share that with your colleagues. So give them some thought to that question as we go through our presenters. And after we hear the presentations, we're going to ask you to share your thoughts in the chat. So with that, it's my pleasure to introduce our first speaker today, Dr. Jane Fogg. Jane is a physician leader and executive with broad experience leading healthcare delivery focused on primary care, system redesign, and value-based delivery models. She recently joined the American Medical Association as Physician Director of Organizational Transformation for the Division of Professional Satisfaction and Practice Sustainability. At AMA, she leads the development of learning networks and collaboratives on organizational transformation that delivers physician satisfaction, and she also supports research, recognition, and activation in her work unit. So welcome, Jane. We're thrilled to have you here today, and I'll turn it over to you.
Thank you so much, and good morning or good afternoon, wherever you are, and thank you again for having me. I'm pleased to be here to talk about the role of professional satisfaction and patient safety, and how we might design our systems to uphold both goals. I'm speaking to you in my role at the American Medical Association, where I work with a dedicated team who wants to reduce professional burnout and improve the care we deliver to all patients in all communities across the country. We offer pragmatic strategies that improve clinical practice and reduce epidemic burnout that is currently plaguing our profession. But I also come with my experience as a primary care physician and as a physician leader for over 3 decades. My leadership work spanned across value-based care, population health, primary care, strengthening healthcare systems. And from all of those different experiences and that lens, I can easily see the relationship between the systems that support safety and the ones that enable professional satisfaction. These issues are related. So knowing that, I think we can align strategies that support both endeavors. Next slide. No disclosures. Next. My agenda, we'll talk a little bit about the relationship and more about the definitions, drivers, and data around burnout, and certainly about strategies and solutions. I will touch on relational care, which is an important value in the healthcare setting that I also believe greatly impacts safety. And I'll end with AMA resources, and you'll find links in many of these slides that will be shared so you can look these up yourself. Next. So why talk about professional burnout when the goal here is to think about the patient, to focus on improving the safety for the patient? Simply put, to improve safety, we must also improve the system of care for our healthcare teams so that all of them can deliver the best care possible. And we need to understand the role of the individual practitioner and team members in safety outcomes. There's been tremendous work across my practice time looking at patient safety in a lens of systems approach and applying strategies to things like medication management, transitions of care, communication across team members, and a variety of team-based strategies. Electronic health records, data and analytics have certainly helped advance our capabilities in safety, but they've also added some new challenges that negatively impact our goals. And unfortunately, at this juncture, we just haven't made enough progress across this country to ensure that every patient has a guaranteed safe experience when they enter the healthcare system. So I think we need to expand beyond looking at systems and start to look at the human factors, the individual factors that might be at play when we're looking at our outcomes. And we have plenty of research that tells us that physician burnout impacts patient experience, it impacts quality and outcomes, it impacts the cost of care. And indeed, when we talk to doctors, we know it also impacts their perception of medical error. This paper is one of many, but it is a systematic review from 2021, looking only at hospital-based settings, but looking at specific studies that looked at the relationship between the burnout or the engagement of the professionals and the safety culture or outcomes. And they did see relationships. Importantly, though, the authors encourage us to continue to do this research. There is a relationship here, but we don't know enough about it to be certain about the best direction to go. Next slide. We do know that if we ask physicians what's their perspective on burnout and how it impacts errors, they report that they are twice as likely to have caused a medical error if they are burnt out. And this is after adjusting for specialty, work hours, fatigue, and the safety rating of their setting. So physicians themselves, we report more errors when we are burnt out. Next. So how do we think about why this may be happening? And this is my illustration of how I think of some of the factors here. Above all, physicians strive to deliver the best care they can to help their patients navigate sickness and navigate health. And today you need a high functioning clinical practice to do that. Caring for patients is a team sport. You need a range of expertise, a variety of services. Patients travel across a variety of care continuums. And so we need systems that we can depend on. And when we work in that high functioning system as a physician, we feel more satisfied. We're able to do our best job. But many physicians, many nurses, many care team members do not work in ideal conditions. And the types of things that I'm talking about that inform whether that system is working well, some of them are on the bottom. Stable relationships, relationships between team members, between colleagues, knowing the people you're working with and getting better as a team. Continuity of care with your patient, knowing your patient and your patient knowing you. Team care, effectively designed electronic health records, highly reliable systems, and above all, optimizing the work environment to avoid cognitive overload, to ensure that all humans working in the healthcare setting can do their best because they are not overwhelmed with excessive information. So let's step back a little and examine what burnout is and why it happens. Next. Next. So burnout is a well-characterized syndrome in the context of occupation, characterized by three main things: a feeling of persistent emotional exhaustion, feeling cynical and detached from work, not caring, not being engaged, and lastly, a sense of low personal accomplishment or decreased efficacy at work, feeling that you're just not able to make a difference. And this is not working too hard. This is not being tired. This is a syndrome that has a persistent feeling that lets you disengage from your work environment. Many of us work hard and don't feel burnout. So what's the impact of burnout? You could think about it just impacts the physician or the nurse who is experiencing it, but that's actually not true. It impacts us in a variety of ways. If we're looking simply at workforce stability, which seems obvious, burnout causes more turnover. Turnover disrupts relationships, whether those are the relationships on the care team or whether that's your relationship with your doctor. In primary care, it reduces access tremendously. As PCPs retire early or turnover for other opportunities, many of us have scrambled to find a new primary care physician, which can be quite a challenge. We have lots of data about patients' effects of burnout. They have a reduced experience, reduced quality and outcomes. And importantly, there's a heavy cost to the organization, to the system. Studies have estimated $4.6 billion a year spent on the cost of replacing physicians who are leaving early for reasons of burnout. We also know that we spend more money. It costs the system when PCPs turn over. And we can see that in Medicare studies that I'll show later. But absolutely, it does affect the physician. And sadly, we see higher rates of death, divorce, addiction, suicide, all outcomes that we want to avoid. Next. So how bad is it? It's bad, but how much of it do we see? Well, fortunately, we've been tracking it for quite a while. And we have one study here. This group has surveyed physicians every 3 years since 2011 and compared it against a similar sample of the population that are not physicians. And what you can see in the dotted lines is that consistently, physicians are reporting higher levels of burnout than the general population. And the spike up in 2021 was a year where they did a repeat study because of the pandemic and saw 63% of physicians reporting burnout. We have a new, studies from 2023 are not yet released, but we'll have new numbers from that. We also have a second data source. The American Medical Association provides in our mission work, we provide a freely available organizational survey instrument we call it the organizational biopsy. Next slide. This biopsy allows organizations to assess not just burnout, but satisfaction, leadership, culture, efficiency of practice, a variety of things that let them better understand how their workforce is doing. We also pool that data so we're able to provide benchmarks. We also use the data to drive research and find further associations in how we manage our practices and how that might affect burnout. These are the key performance indicators from 2023. And sadly, you can see, although it's improved from 63%, 48% of our physicians are experiencing burnout, an improvement from last year, but still half of us. And our advanced practice colleagues, 50% of them are experiencing burnout. This means we are more likely to report an intention to leave. And we know that when we report an intention to leave, about a third of the time we actually do that. A third of the workforce is saying they intend to leave in the next 2 years. And half of us feel valued. This is simply not good. Next. So what causes this? And the most important thing I can say today is that although burnout is manifesting in individuals, it absolutely originates in systems. It is not a weakness. It is not a lack of resilience. The type of systems that affect burnout, certainly the electronic health record has been named routinely as something that is not optimized for clinical practice and human workflow. We know that many practice inefficiencies, lack of adequate team-based care, and obstacles and regulatory burdens in patient care slow us down and add to burnout. And we sum this up by something we call physician task load. Next slide. So we used to think that your doctor's ability to make an accurate diagnosis was based solely on their training, their skills, their expertise. But now we know more about cognition, about how all of us can work at the top of our capabilities, and it's dependent on factors outside of our training and our innate experience. It includes context, bias, resources, but also the physical, social, and technological environment. So it's not just how well trained or smart your doctor is, it's how and where they work. To illustrate this, imagine that I'm taking care of a patient with heart failure, diabetes, and kidney failure. I'm constantly evaluating lab tests, symptoms, and adjusting medications to balance these different conditions. To do this is complicated medicine, but it's what I'm trained to do and what I really enjoy doing. But how do I do it? I have to update the medical record and renew medications and change dosages on a regular basis. It's cumbersome and slow. I can't find the most recent medication change from their last hospitalization. It takes me time to do that. I'm constantly having to be doing authorizations when a new medication comes up that might even been prescribed by another doctor, but the patient needs it now and we have to get the authorization to the insurance company. All of these types of hurdles and obstacles that slow me down in caring for my patient, this is that extrinsic workload. This is that environment that becomes burdensome. This is what is actually driving the burnout, not the complicated task of taking care of a patient with heart failure. It's how you do it, the environment in which you do it. So that is that task load. And we see it in a lot of everyday situations. Next slide. Frequently, when you're in an exam room with a patient having a conversation or doing an evaluation, there's a knock on the door, or there's a text message asking you to put an order in on another patient because they need something urgently. Or your patient finally shows up and they've missed many appointments and you can't locate someone to help you with transportation at the time that the patient's in the office. Or you're reconciling the medications and it's cumbersome to do it and you can't figure out how to make sure it's accurate every time they come in. And you have a tickler list because every time you refer or put an order in, you're not 100% sure that the patient's going to receive that necessary care. And so you track it yourself to make sure it happens. And most of all, what most of us suffer from, whether we are in primary care or at a facility taking care of patients on a surgical ward, is information overload. Electronic tech with the technology has allowed us to see and know more, but it also has not provided a stream of information that is prioritized, where things are delegated away so that I'm only dealing with what I need to deal with. Most of us are wading through lots of information every day, lots of interruptions. That's extrinsic load. Next. So enough about how bad it is. These are the strategies and solutions that we like to think about. Next. So this is a familiar framework for many, the Stanford Well model, which talks about an overall comprehensive strategy to working on burnout. And certainly in the bottom, personal resilience is an important thing to remember. But for many years, this was the main strategy by which we tried to mitigate burnout. Meditation, yoga, retreats, all of that. But it's simply not enough if the driver of the burnout is the system we're working in. So we have to think about the culture of wellness, and that includes how well our leaders are trained and skilled at developing wellness and developing their teams. And think about aspects of our culture where we have things like peer support, where we have ways for all people delivering care to be engaged in the process of improvement. Those are the types of culture and leadership things that are critical. But I want to talk a little bit about efficiency of practice. This doesn't mean making you go faster and harder. These are the things that allow you to do your work well. Having an electronic health record that is optimized so that you can provide the best care you can, having a team, having the infrastructure and operations run well, and certainly reducing administrative burden. So these are some of the resources we have that are all publicly available on our website. Next. We have these playbooks, which are a great place to start. This QR code will take you there. They summarize many of the podcasts and toolkits we do. And so they're a wealth of information on ways in which you can change your practice to improve things. Next. I did quite a bit of work in EHR optimization and reducing inbox reduction. And so we both have resources here as well as on the AMA, but as well as in other publications. This is an incredibly important area of work, and many people are focused on it as a priority. Again, information overload is where we make mistakes, no matter how smart or well-trained we are. Next. When we talk about how we change clinical practice, we talk about stopping unnecessary work, but sharing necessary work. Sharing necessary work means having team care and workflows, planning for the patient's visit ahead of time, and sharing the work of that visit so that we more reliably do everything they need, rather than just relying on the physician or the APP to do all of the work. Documentation drags many of us down and keeps people up late at night trying to keep up with documentation. Beyond AI, team documentation, having scribes, having staff members document with you is a great way to engage more team members in the care team. Simple steps like changing your prescription renewal practices can save a great deal of time, and certainly the inbox kit. Next. And when we talk about teams, it's not just the workflows they do, but how we develop that team. Just like we're developing a culture of safety, we need to develop a culture of high performance teams where trust, empathy, relationship, communication are values we share. We have complementary skills, shared purpose, mutual accountability. This leads to great outputs. Next. Practice operations, one of my passions, as I spent many a year in this area, but thinking about how the practice runs, thinking about the reliability of things that are as simple as, are the phones answered? Does the scheduling work? Do the referral systems reliably get patients where they need to be? Can the patient get care 24/7, whether it's on-call service or off-hours air? How we coordinate across a multitude of different facets of our organization and care continuum. And now we have timely communication and access to relevant clinical information at every point of care. Next. This is a recently published playbook that we're quite proud of, and we're continuing to do work in this area. We recognize that many of us have overinterpreted regulations and rules to the point where we've lost the purpose of that regulation. If the purpose was to make things safer or provide higher quality care, sometimes we've set it up in a way that actually impedes on that. And so we invite people to read this and think about the way in which we interpret our regulations and how we might do a better job of that to get the goal we want, but also to make it workable for all the team members. Next. And most importantly, Dr. Christine Sinsky, who has led this work at the AMA for many years, relationships are our superpower. There are many pieces of evidence here about how relationships within healthcare improve the care delivery we've had. And I invite you to read these papers, which I think are a great basis of thinking about how we're engineering care. Next. 2 studies from that, stable care teams, one just looking at in the emergency room. If you present with symptoms of an ischemic stroke, you need to get treatment immediately. And teams that worked together longer, that had familiarity, had a shorter, quote, door to needle time, shortest time for you to get the treatment you need. Surgeons and anesthesiologists that work together more often have reduced patient morbidity after complex gastrointestinal surgery. Just knowing each other led to better outcomes. Next. And certainly one that I felt, when you have a stable relationship between a medical assistant and a physician, you can create better care, whether it's being more productive, being more satisfied, but most importantly, delivering greater quality, improving diabetic control, offering preventative services more regularly. My medical assistant over my last 10 years of practice improved my vaccination rates because she took on the process of evaluating what was needed and administrating it with my partnership, and she made me better. Next. And this is the article that I alluded to in the beginning, but just showing that when a primary care physician turns over, we see increased expenditures using Medicare data. So did all the patients just get sicker after their PCP left, or is something else happening? We're spending more money, and I could say when you're taking care of a patient in continuity versus taking care of a patient in an urgent setting where you don't know them, it's much harder to have that context to inform your decision making. You could do a better job giving the right care if you know the patient. Next. So this is my team, fantastic people, and the type of work we do on the next slide. We offer all mission driven, this freely available. We offer measurement. We have a compendium of resources on action steps. We do speaking engagements such as this, but everything I'm talking about today, you can find on our website. We have a recognition program to elevate healthcare practices and systems that are investing in joy in medicine. We have a lot of convening opportunities, and we certainly try to drive a lot of research because this is an expanding area that we need to continue to pursue. Next. So that's it. I will stop there. 21 minutes, just made it. Thank you so much.
Great. Thank you so much, Jane. That was really interesting, and it's so important for us to think about how safety design, or the lack of it, can contribute and impact our workforce and then ultimately patients. So thank you so much for that. We will do questions at the end so that we have time to get through all of our presenters today. So I'm going to switch gears a little bit and now talk about a different aspect of safety engineering. And so it's my pleasure to introduce our next 2 speakers. So first I will introduce Dr. Bruce Hansel, who joined ECRI in 1984 as a project engineer. During his time at ECRI, he has done several device evaluations, countless hazard investigations, and many special projects. In 1986, he and a colleague formed the Accident and Forensic Investigation Group, which is a small group of ECRI engineers focused on performing third-party investigations and assisting healthcare facilities with their own internal investigations for the purpose of preventing recurrence. He has served as the director of the group for many years and has performed approximately 1,000 investigations. Currently, he is the chief scientist for device safety at ECRI, and he will be joined by Dr. Jeffrey Feldman, an anesthesiologist at the Children's Hospital of Philadelphia and an adjunct professor at the Perelman School of Medicine. Dr. Feldman has a special interest in the use of technology in patient care and is past president of the Society for Technology in Anesthesia and former editor of the section on computing and technology for anesthesia and analgesia. He serves as the chair of the Committee on Technology for the Anesthesia Patient Safety Foundation and is a member of the APSF Board of Directors. So welcome, Dr. Hansel and Dr. Feldman, and I will turn it over to you.
Thank you. Well, good afternoon, everybody. I'd like to thank AHRQ and the Alliance for inviting ECRI to participate in this worthy discussion. What we're going to talk about this afternoon is surgical fire prevention. And so we can go on to the next slide. So our basic agenda is going to be discussing hazard identification, investigation, and remediation. Give you some examples of quick fixes where engineering solutions have been applied to different types of problems. And then we're going to get into actual surgical fire prevention and clinical implications of prevention strategies. So next slide, please. So ECRI, for those of you who may not be familiar with us, started back in the late 1960s, and we're an independent provider of technology information, and we actually perform comparative evaluation of medical devices. That's one of the means by which we find out about hazardous products. Another means is we also started in the early 70s the first national medical device problem reporting system. So hospitals across the nation participate in providing us medical device problem reports, which we then investigate, and that's another means of us finding out about hazardous products. The other thing we do is, as I said earlier or during the introduction, is we do actual accident investigation for facilities, or we assist them doing their internal investigations. So that's another way in which, one, we interface directly with the hospitals where we get a good idea of what the process is in which the product is used. The investigation involves knowing the environment of use in all aspects of that. So in the process of doing those, we often see ways in which engineering solutions could be applied to solve sometimes process problems or solve engineering deficiencies with products to make them better and safer. So in these three areas here, this is how we focus and apply on hazard investigation. One of the things you need to have when you work for ECRI is a hazard gene, I should say. So you need to be able to look at something and immediately see where there may be problems with it. So on to the next slide, please. So here are some of those examples about technology where quick fixes can be applied from an engineering perspective of the equipment. You can do design on process and you can do design on technology. These are basically more technological answers. So one example is reducing the risk of a return electrode burn by using dual foil pads and not using single foil pads, because dual foil pads have the capability of interfacing with an electrosurgical generator to allow it to know when the pad is coming off. So if a pad comes off, it reduces the surface area for current to get out of the body and increases the likelihood of a burn due to current concentration. Another one is properly configuring overrides for pharmaceutical dispensing cabinets. You see a great deal of overrides charted that in some cases really aren't necessary and need better control. The next one is inflatable pressure infusers. That's a pet peeve of mine. Those are inflatable bags that have a pocket in which you put an IV bag, and then you can pump this pocket up to squeeze the solution out of the IV bag. The unfortunate thing is most IV bags come with air in them, and you can squeeze that air into the patient under some circumstances, in which you can have a lethal outcome there. Another thing that we look at is manufacturer IFUs to make sure that their instructions for use are clear and understandable, and that they're actually practical. So a lot of times those instructions are contradictory from one thing to the next. So that's another area where an engineering solution in terms of proper instruction can be implemented. Next slide, please. So let's get on to the meat of this, which is surgical fires. So surgical fires can be horrendous. These are both facial fires, but there are other kinds of surgical fires that don't involve the exterior of the body. You can have an airway fire by ignition of an endotracheal tube. You can also have ignition of endogenous bowel gases during the application of electrosurgery or argon beam coagulation in the GI tract and explode somebody's stomach or their intestine. I've investigated several of those cases, some fatal. So the main way in which surgical fires are prevented at this point in time is more about controlling the process as opposed to having engineering solutions. There is a big, in my opinion, engineering solution gap. So physicians, nurses, clinicians in general are well-educated, very smart people and creative. So this is an opportunity for people to think about how they would go about using product alteration or have ideas to prevent an ignition source from igniting any fuel in the operative space. But there are three main things, which we've come to call the fire triangle, that are necessary to have a fire. You have to have a fuel, and in these cases, usually prep solutions, alcohol-based ones. Drapes and towels are among those things that can get ignited, and once those get ignited, they can spread to an oxygen mask. So you can see in these cases what happens is the mask gets ignited. Once it melts, then it begins to adhere to the skin. So that also becomes a fuel. So the next thing that has to be controlled is the oxidizer, which in anesthesia, the two main ones, and Dr. Feldman can talk more about this because he uses these in his daily practice. Oxygen and nitrous oxide are the two main ones. Oftentimes you don't think of nitrous oxide as being an oxidizer, but it can contribute to being an oxygen source for combustion. And then the ignition. So in most surgical procedures, your ignition source is either going to be ESU, laser, or the term cautery, which would be like a hot wire pin that's used for cauterization. Another thing can be argon beam coagulation, which is still an electrosurgical mediated means of ignition. So interestingly about those, there are different groups of people who are involved in handling those. So the ignition is generally always the surgeon, or maybe there's a technician that's hitting a foot switch at the directions of the surgeon. The oxidizer is generally in the hands of the anesthetist, be CRNA or anesthesiologist. The fuel prep can be handled by several individuals. The surgeon often can be involved in doing prepping, OR techs and nurses. So there's a little larger spread in terms of who might be handling those aspects of the fire triangle. But it comes down to communication in this fire triangle to actually prevent a fire. So let's go on to the next slide. Another thing that I'd like to point out is that ECRI doesn't just work in a vacuum. We look at other industries' means of fire prevention and how they go about it. I'm not going to go into this with a lot of detail, but I just want you to know that we are interested in hearing from any group who has ideas about fire prevention and how that might be applied to the healthcare setting. Next slide, please. So where we see most fires in terms of anatomically, most of those occur above the nipple line, face, head, neck, upper chest. And the next would be in the airway, then elsewhere on the body, and like down on the chest. You can also have them in just about actually anywhere where you're applying cautery. And then in the body, like the ones I mentioned earlier about bowel gas, for example. One of the things that, from an engineering solution perspective, starting years ago after my first investigation of a fatal explosion in a patient during a colonoscopy, I began to advocate for use of carbon dioxide insufflation. And over the years, it's been more and more and more adopted because carbon dioxide is basically a fire extinguisher. It doesn't support combustion. So usually in colonoscopies or other endoscopies, you use an insufflator to expand the operative space, and that most of those insufflators just pump room air in. So as long as you have a flammable vapor like bowel gas, which is mainly methane, some oxygen, and an ignition source, you can ignite that. You don't need necessarily oxygen enrichment, which is oxygen greater than 21%, which is air. So using CO2 just essentially takes the whole possibility of igniting anything in the GI tract off the table. So we can go on to the next slide. So ECRI has developed a poster to assist clinical staff in making an assessment of fire risk and what to do. I'm not going to read through everything on that poster because it's a little granular, but the main bullet points are to use a pre-op timeout to assess fire risk and discuss mitigation efforts. And let me say here, discuss mitigation efforts is critical because I just investigated a fire where they had a fire timeout, but they had no discussion at all. And there was no discussion as to when I'm going to use cautery. There's no discussion as to whether I'm turning oxygen down. And so even though there was a fire timeout, they graded a high risk, actually maximum risk, because it was on the face with an open mask. They still had a fire. So there's the old saw that you can lead a horse to water, but you can't make them drink. That's why I think we've reached as far as we can go with defining a process that should prevent the fires. What we need now is more in terms of what kind of engineering solutions could there be in order to prevent fires. So let's go to the next slide, please. This is ECRI worked a few years back with Pennsylvania Patient Safety Authority in looking at surgical fires, and around 2000, I think 10 or 11, we actually collaborated with the Anesthesia Patient Safety Foundation, and both of us together came up with an education video and a fire poster to help assist with lowering the incidence of intraoperative fires. And that trend has continued and continued. So I really believe that, and Jeff can talk more about it, But those efforts have come to fruition. They've borne fruit in that the incidence of fires has come substantially down, but it still could come down even more. And that's what we want to work toward. So as you can see here, the data from the Pennsylvania data shows that most of these are above the nipple line. So, and most of those are on the face. So a lot of these are cosmetic procedures where you're not using the cautery, but just briefly, but that's all you need. Little embers can fly off the electrosurgical blade. They're almost microscopic. They land on the fine villus hair on exposed skin. And it's essentially like flipping a lit cigarette into a dry grass field. It spreads incredibly quickly, faster than you can see, and then it reaches the next available fuel, which can be a huck towel. And the fuzz of the fiber of the huck towel also acts like a grass field. And then it reaches the drape and can actually get beneath the drape. And if there's oxygen under the drapes that has accumulated, then the whole drape can go up. So it's entrapment of oxygen that leads to these larger fires or burning through of the tubing that's delivering the oxygen to the patient. I've seen cases where it almost looks like a fire-breathing dragon, because once the tubing burns through, it becomes almost like a blowtorch. Next slide, please. So this is a reduction strategy to go through in terms of deciding what you need to do in terms of assessing risk. So the first thing to ask is the patient at risk of surgical fire. So that's going to, if that turns out to be no, you can proceed. But if there's anything that changes about either anything in the fire triangle that changes, you have to reassess. If there is a risk, then you have to ask, does the patient really require supplemental oxygen? And if no, you use room air sedation. You don't use oxygen. Oxygen is probably way overused. Dr. Feldman can talk about that as well. Next is the oxygen concentration required to be above 30% to keep the hemoglobin of the patient saturated. And if the answer to that is no, use a delivery device such as a blender or the common gas outlet of the anesthesia machine to maintain oxygen below 30%. And that's another engineering solution that I think is near and dear to Dr. Feldman's heart, is use of O2 blenders, having them available in all anesthesia settings so that you have an easy way to control auxiliary oxygen, because a lot of these fires involve auxiliary oxygen, not oxygen from, as mentioned earlier, the common gas outlet from the machine, where you'd get anesthesia vapors as if you were delivering an inhalation anesthetic via tube. So the next one is, and best way to prevent a surgical fire is to have a secure airway with an endotracheal tube, where you don't have oxygen leaking to the atmosphere around the patient that can ignite. So more fires could be prevented if more airways were actually used. Next slide, please. So in terms of responding to a surgical fire, ECRI has also developed a poster to assist people to know what to do. And like I said before, I won't go through reading all those, but basically the same people who are involved in their part of the fire triangle respond to that part of the fire triangle. So whoever's in control of oxygen has to turn it off immediately. Of course, you mitigate risk injury, you tend to the patient, and then the other is to get any burning materials off the patient. It's duration of exposure to the flame that really begins to increase the seriousness of the injury. You can have a fire that's very brief, that may singe some hair, but doesn't damage the skin. But the longer exposure there is to flame, the longer the fire can continue, the more things can catch, the more it can spread, and the more damage it can do to the patient. So there are several means of extinguishing. CO2 is the best for these types of fire, and we recommend for ones that you can't pad out with saline, using a 5-pound small CO2 fire extinguisher. So with that, I'm going to turn the rest of this over to my very able colleague, Dr. Philman.
Thanks very much, Bruce. I hope everyone can hear me. I think we're a little short on time, so I'm going to try to be pithy in my remarks. I think the main take-home points that I want to emphasize is that these fires are 100% preventable, and they still occur, even though we know exactly how to prevent them. And the obstacles to preventing them in the future are technological in part, and also cultural in the way people practice. Just to give a sense of why these fires continue to be a problem, this slide is useful. It shows the incidence in closed claims. The American Society of Anesthesiologists maintains a database of closed malpractice claims, and it shows the increase in the claims related to cautery fires during monitored anesthesia care. Those are sedation procedures where often the patient's airway is not controlled and supplemental oxygen is provided. And I think this reflects a significant change of practice, both the growth in outpatient surgery, as well as the introduction of propofol, which allowed us to sedate patients comfortably for procedures without necessarily controlling the airway, placing an endotracheal tube, for example. But culturally, we are, as providers, taught to provide oxygen routinely during those sedation procedures. And that's really the root cause of the fire risk, is this routine use of oxygen without a controlled airway. And the source of oxygen in most procedural locations still remains 100% oxygen that's connected to a supply. Next slide, please. So oxygen, you can hit this a couple of times to bring the points up. Oxygen is the problem, and we are the accomplice. We deliver it, and the smoking gun is the oxygen flow meter, which sits next to the bedside in most locations. Next slide, please. There is some mislead, even though there's been a lot of work by the American Society of Anesthesiologists, the APSF, the FDA, ECRI, many organizations to foster fire prevention. There is a little bit of misleading information that's still in the literature. And this relates to the ASA advisory, which was first published around 2008 or 9, I believe. But part of their prevention strategies recommending communicating with the surgeon, stopping the delivery of oxygen prior to igniting a heat source, and then waiting for the oxygen to dissipate from the environment. And next slide, please. The problem with that approach, next slide. The problem with that approach is that if you've constructed an anesthetic that requires delivering a high concentration of oxygen to prevent hypoxemia, what happens when you turn off the oxygen? The patient will become hypoxemic. And furthermore, waiting, I don't know too many surgeons who are really patient. And so waiting the 2 or 3 minutes that you might need to wait to really be sure that oxygen is dissipated is a little bit of a challenge in the environment. Next slide, please. So I think there are a few opportunities to ensure surgical fire prevention that we need to work on in the future. So culturally, there are barriers, even in short procedures, to controlling the airway. Surgeons, nurses that we work with may view it as for a short procedure, too invasive to place an endotracheal tube or another airway, when in fact the incremental risk in most patients is negligible, particularly when you compare it to the risk of a fire. And I think that culturally, anesthesia providers still need to begin to recognize more of the risk of delivering that 100% oxygen from that bedside flow meter. Educationally, there is opportunity to teach sedation techniques that can be quite safe, but do not require providing enriched oxygen concentrations. And from a technology perspective, while their oxygen air blender technology that allows you to lower the oxygen concentration that's delivered is well established and exists. It's an old technology. It is not currently standardized in every anesthetizing location, and having that available would facilitate safer practices. Next slide, please. So the key takeaways, I don't know who's in the audience, but if you're a patient, you can ask the surgical team how you will be anesthetized, and if it's a high-risk fire scenario, particularly surgery on the upper part of the body, what are the fire prevention strategies that will be used? Be a great reminder to the team to really be mindful about how they prevent fire. And engineers, you can design equipment to foster compliance with prevention strategies, in particular, ready access to oxygen air blenders. And for providers, that timeout scenario really needs to be taken seriously, where the team recognizes the risk, agrees on prevention strategies, particularly oxygen delivery, and then follows that strategies. And if all those things are done, these fires will go away. They are 100% preventable. Next slide. I believe I'm done with those remarks. There's some resources here for anyone that's interested, and thank you so much for the invitation and the time to speak today.
Great. Thank you so much, Bruce and Jeff, for that very informative set of presentations on a high-risk issue in patient safety with some known solutions that people could be using. We are approaching the top of the hour, so we don't really have time for live questions today. I would encourage anyone with questions to please post them into the chat. And in just a moment, we'll have a slide with an email address where you can send your follow-up questions. Definitely want to thank Jane, Bruce, and Jeff today. I think one of the common themes we heard from all three of you is that there are solutions to some of the things people are dealing with that are out there right now that you can leverage to make your systems safer and to make a safer work environment for employees so that staff and clinicians are not feeling stressed of being in a situation where they don't have the resources to do their work effectively. So really interesting topics for today. Before we close, a couple of upcoming events of interest that we want to share with you. And just a reminder, this was our starting question. It's in the chat. If you heard something today that you think you might want to redesign your own system, we'd love to see your response in the chat. You can also email it to us with the contact info I'll share in a moment. An upcoming event that we think might be of interest for everyone, if we could go to the next slide, please. There will be a webcast coming up on enhancing surgical team communication. So very great segue from what we just heard about surgical fires. Communication in the operating room is absolutely essential to fire prevention as well as preventing other types of adverse events. So here's information on that webinar, which will be held next week and is being offered through AHRQ. Our next monthly webinar for the National Action Alliance will be on August 20th, same time, and we will be focusing on promoting safe care everywhere by leveraging a competency framework. So that will be the focus of our webinar on August 20th. And I'm looking forward to hearing our presenters and hopefully hearing from many of you again next month. You can stay connected to the Alliance by subscribing to our monthly bulletin, and our email address is at the bottom. If you have any follow-ups or questions for today's presenters, please feel free to send them to that email address because we did not have enough time to take your questions live. Apologies for that, but we will be available if you'd like to send them. So again, thank you, Jane, Bruce, and Jeff for joining us today. Thank you for everyone who is attending or listening to the recording. Have a great and safe day, and we'll talk to you next month.